I'd like to give us a hand. We've made it all the way down the upper limb to get this far. Okay, that's a corny opening, I know. So to be more serious, I'll add that the human hand holds some amazing architecture, as you'll see, and is one of the anatomical features that separates us from all other animal life, except for our primate relatives. Our hands allow us to do everything from simple actions like scratching our heads and brushing our teeth, to complicated tasks like using a keyboard, whether on a piano or a computer, and so many other activities in between. So let's take a look at the musculoskeletal anatomy of this evolutionary marvel that contributes so much to our humanity. Let's first consider a clinical scenario. A novice woodworker was using a chisel when he attempted a different angle and the chisel cut fairly deeply into the palm of his left hand. The result left the whole muscle mass at the base of his thumb essentially paralyzed, except he could still perform thumb extension and adduction. He also lost fine motor control over his index and middle fingers, but could still move them. He had no feeling in his index and middle fingers or in the lateral side of his ring finger, but the skin of the rest of his hand and fingers was unaffected. What specific damage caused these symptoms? We've seen muscles in the forearm that move the wrist, but we've yet to look at the wrist in detail. The wrist holds a complex of 8 small bones known as carpals, but only 2 of them have direct articulation with one of the 2 forearm bones. The distal radius widens at its end to form a joint with 2 of the 8 carpals, while the ulna has an articular disc at its distal end that prevents it from direct articulation with any carpals. And most people don't realize that the carpals are actually located within the hand itself. So look at your own wrist. See the wrist crease that separates your forearm and your hand? The carpals are distal to that crease in the proximal most region of the hand. The carpals are said to be in 2 rows of 4. The proximal row contains the scaphoid at the lateral or thumb side, followed by the lunate, then the triquetrum medially. However, the 4th carpal in that proximal row, the pisiform, is not aligned next to the triquetrum. It's stacked on the triquetrum's anterior side. Typically, only the scaphoid and lunate articulate with the distal radius. Then the distal row of 4 carpals are in a line from lateral to medial. They're the trapezium, trapezoid, capitate, and hamate. Now there's a slightly naughty mnemonic for remembering the carpals of the wrist. It goes like this. Some lovers try positions that they can't handle. So from lateral to medial, the carpals of the proximal row are the scaphoid, lunate, triquetrum, and pisiform. That's the some lovers try positions part of the saying. And then for the that they can't handle, from lateral to medial are the trapezium, trapezoid, capitate, and hamate. Because there are so many carpals that begin with the letter T, I tell my students, trapezium is by the thumb, trapezoid is on the inside. Now that leaves the 3rd T-named carpal, the triquetrum, on its own in the proximal row. But wait, there's more. To understand the carpal tunnel, we need to consider a few specific landmarks on some of the carpals. The scaphoid and trapezium, the lateralmost members of the proximal and distal row respectively, each have a tubercle projecting from their anterior surface. Medially, remember that the pisiform bone is stacked on the triquetrum in the proximal row, so it projects anteriorly. Plus, the hamate has an anterior feature called its hook. The result is that laterally, the tubercles of the scaphoid and trapezium form the attachments of the deep part of the flexor retinaculum, which forms the carpal tunnel, and the pisiform and hook of the hamate allow the medial attachment of the flexor retinaculum. Now, it may seem like a fine point, but the carpal tunnel isn't actually a thing. It's an open passageway, or as I like to say, it's the absence of a thing. The carpal tunnel is really a tube made out of the flexor retinaculum's attachments to 4 of the carpals. Do you remember the 3 muscles with tendons that pass through the carpal tunnel? If you said the flexor digitorum superficialis, flexor digitorum profundus, and flexor pollicis longus, you're right. Each tendon is in its own synovial sheath, and so when irritated or inflamed, the sheaths can swell up, causing pressure within the carpal tunnel that compresses the nerve that travels with those tendons. Do you remember which nerve that was? Your options in the anterior forearm are the median and ulnar nerves. If you said median, you're correct. Carpal tunnel is really a median nerve issue, sometimes thought to be caused by overuse of the flexor muscles in the forearm, but it can also occur after an injury or secondary to various medical conditions. Oftentimes, though, carpal tunnel syndrome is caused by a combination of issues, or it has an unknown etiology, which means an unknown cause. People with carpal tunnel syndrome often experience numbness and tingling in their hand, typically in the lateral aspects of the hand, the thumb through the lateral side of the ring finger, but not in the medial part of the ring finger, since its skin and that of the little finger are supplied by the ulnar nerve. These sensations may occur when they grasp something with a fist, like a steering wheel or handlebars, when holding a book, or in my case, when holding dissection tools. In fact, people with carpal tunnel syndrome may get muscle weakness to the point of dropping things. During the night, the pain can become so intense that it wakes a person up. The pain may even travel up the arm, as happened with me. And when an electromyogram test showed I was possibly headed for permanent nerve damage, I decided to have surgery. A carpal tunnel surgery simply opens the skin and then releases the flexor retinaculum by cutting through it. The flexor retinaculum then heals on its own in a roomier size of larger diameter. No internal stitches needed. Now, let's move distally from the carpals. The 5 metacarpals are not in a 1-to-1 ratio with the carpals, since there are 4 carpals in the distal row. Each of the 5 metacarpals has a proximal base followed by its shaft, and the head of each metacarpal is distal. They don't have specific names. The metacarpals are instead referred to by Roman numerals. The most lateral on the thumb side is metacarpal 1, and the most medial is metacarpal 5 on the little finger side. The head of each metacarpal, which we call a knuckle, articulates with the proximal phalanx in each digit. Now remember, the thumb has only 2 phalanges, a proximal and distal, while each of the fingers has 3, a proximal, middle, and distal. Now, each phalanx, no matter how large or small, is said to have a proximal base, a shaft, and a distal head. There are 2 other bones in each hand. 2 tiny sesamoid bones form at the head of the first metacarpal within the tendons of one of the muscles of the hand, as we'll soon see. The wrist is anatomically known as the radiocarpal joint. It's a condyloid or ellipsoidal joint by shape. The distal radius is slightly concave, and the scaphoid and lunate of the carpal group are convex. For this reason, the wrist is not a simple hinge joint, but allows flexion and extension as well as radial and ulnar deviation, all caused by muscles within the forearm. However, like a hinge joint, there are radial and ulnar collateral ligaments at the wrist, as we saw at the elbow. So you have to be specific as to whether you're referring to the radial collateral ligament of the wrist, for example, or of the elbow. The wrist radial collateral ligament attaches from the styloid process of the radius to the scaphoid and trapezium, which are the proximal and distal carpals on the lateral side, respectively. The ulnar collateral ligament of the wrist attaches the styloid process of the ulna to the triquetrum and the pisiform bone stacked on it. Among the carpals, there are synovial planar gliding joints. These gliding joints allow slight movements of carpals against their neighbors. Lots of intercarpal ligaments hold the bones of the wrist together. There are also radiocarpal and ulnar carpal ligaments to further support the wrist joint. Most carpometacarpal joints are also planar gliding joints that don't allow much movement. But the carpometacarpal joint on the thumb is a saddle joint. That's a joint in which one bone acts like a saddle and the other fits into it like a rider. The result is our incredible primate thumb that can flex, extend, abduct, adduct, and rotate into opposition. The metacarpophalangeal joints at the head of each metacarpal are ellipsoidal or condylar, since the head of each metacarpal is a rounded knob and the base of each proximal phalanx is concave. Now that spooning shape allows more movement than a typical hinge joint. So not only flexion and extension, but some side-to-side movement as well. It also allows some abduction and adduction of the fingers. But once within a finger or the thumb, our interphalangeal joints are hinge joints with collateral ligaments that only allow flexion and extension. As some of us know all too well, osteoarthritis of the interphalangeal or metacarpophalangeal joints is common, and like other regional wear and tear patterns of arthritis, can relate to hobbies or occupation. But rheumatoid arthritis is a systemic autoimmune condition that preferentially attacks the small joints of the hands as well as those of the feet. Other pathologies, like trigger finger, involve inflammation of digit tendons and their synovial sheaths. They're not a problem with the bones themselves. Now, what about a so-called broken wrist? Well, it is possible to fracture a carpal, especially the scaphoid, but that's not what's typically meant by a broken wrist. Have you ever heard of a Fuchs injury? That's an acronym for falling on an outstretched hand. A Fuchs injury is often the cause of a so-called broken wrist, but the fracture is typically a break in the distal radius, common enough to have the eponym Colles fracture. I guess Fuchs could also be the sound that's made as someone is slipping down the stairs. Anyway, the entire force of the fall is transmitted from the palm of the hand through the scaphoid and lunate to the distal radius. The Colles fracture occurs in the radius since the articular disc at the wrist cushions the distal ulna from the blow, although a really hard landing can break both the radius and the ulna. Of course, it's instinctual to use your hand to break your fall, and that just may save your noggin. Another common Fuchs injury is a wrist sprain, in which some of the many ligaments of the wrist can become overstretched or torn. That will often be treated with RICE therapy, rest, ice, compression, and elevation, whereas a distal radius fracture will require some period of immobilization, including a splint or a cast or possibly even surgery. Now, on to the muscles. Intrinsic hand muscles are those completely within the hand, including their origin and insertion, and therefore their action. There are three main muscle groups in the hand. Three thenar muscles that make up the fleshy mass at the base of the thumb, three hypothenar muscles that make up the fleshy mass at the base of the little finger, four muscles in the mid-palmar area, and a tiny skin wrinkling muscle that belongs to none of those groups. As with the anterior forearm, all muscles of the palmar hand are supplied by either the median or ulnar nerves. However, in the forearm, the median nerve supplies most muscles, whereas in the palm of the hand, the ulnar nerve supplies most muscles, as we'll see. Let's start with the tiny muscle of the palmar skin, palmaris brevis. Do you remember the variable muscle of the anterior forearm, palmaris longus? This is its counterpart. Palmaris longus, if you recall, inserted on the flexor retinaculum and palmar aponeurosis. But palmaris brevis is a very small muscle that originates on the flexor retinaculum and palmar aponeurosis. Strangely, like the muscles of facial expression, palmaris brevis inserts on the skin. In this case, the skin on the medial edge of the palm. Its job is to help pick up the slack of the skin of the proximal palm when we perform opposition of our thumb and other fingers, especially the little finger. And while it's not variable like palmaris longus, it does vary in size. Much of the time, palmaris brevis is just a few tiny muscle strands passing transversely across the proximal wrist at this medial edge of the palm. Palmaris brevis is innervated by the ulnar nerve, but immediately after supplying palmaris brevis, the ulnar nerve splits into a superficial branch that is entirely cutaneous to the medial palm and medial digits, and a deep ulnar nerve that supplies most palmar muscles, as we'll see. Let's stay at the medial palm and look at the three hypothenar muscles first. These originate deep to palmaris brevis, taking origin from one or more of the carpals, the flexor retinaculum, or a combination of those. At the most medial edge of the palm is abductor digiti minimi, and we should think of digiti minimi as a single phrase of the little finger. Its counterpart is pollex the thumb. Abductor digiti minimi takes origin off the pisiform bone and the flexor carpi ulnaris tendon. The insertion of abductor digiti minimi is on the medial side of the base of the proximal phalanx of the little finger. Slightly lateral to it is flexor digiti minimi, which originates off the flexor retinaculum and the hook of the hamate, and also inserts on the medial side of the base of the little finger's proximal phalanx. Deeper, but still originating on the flexor retinaculum and hook of the hamate, is the opponens digiti minimi. It inserts all along the medial aspect of the fifth metacarpal. That's the one for the little finger. The fibers of opponens digiti minimi are more obliquely oriented than the abductor or flexor digiti minimi, as you'd expect given its function, since opposition of the little finger means to touch it to the thumb. Abduction fans the pinky finger out and flexion bends it anteriorly. It's worth noting that not only does the little finger have flexor digiti minimi in the palm, in addition to its tendons from flexor digitorum superficialis and profundus, it also gets the extensor digiti minimi muscle from the posterior forearm, in addition to its tendon from extensor digitorum. So while it's no thumb, the little finger is capable of more movements than most other fingers. All of the hypothenar muscles are supplied by the deep branch of the ulnar nerve, which is the muscular branch after the superficial branch forks off to supply skin of the medial hand and digits. Now, the three thenar muscles mirror the hypothenar muscles to some degree. They are abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Remember that two of those have longus buddies in the forearm. Flexor pollicis longus is in the deep anterior forearm, and abductor pollicis longus is one of the snuff box muscles of the posterior forearm. As in the hypothenar group, abductor pollicis brevis is at the edge of the palm, this time the lateral edge. It originates on the tubercles of the scaphoid and trapezium and the flexor retinaculum and inserts on the lateral side of the base of the proximal phalanx of the thumb. I tell my students that to help them sort out the snuff box muscles, note that the tendon of abductor pollicis longus points right to its brevis buddy in the hand. Flexor pollicis brevis is just medial to abductor pollicis brevis. It takes origin on the trapezium and flexor retinaculum and inserts on the base of the thumb's proximal phalanx. It has two heads, a superficial or lateral head and a deep or medial head. It's in those two heads that the sesamoid bones of the thumb grow and act as a guide or a trough to keep the tendon of flexor pollicis longus in position. The final thenar muscle is the opponens pollicis, which is deep to the abductor pollicis brevis. In lab, you usually have to cut abductor pollicis brevis to see opponens pollicis. Opponens pollicis originates on the tubercle of the trapezium and the flexor retinaculum and inserts on the lateral border of the first metacarpal. As with opponens digiti minimi, its fibers are more obliquely directed to allow opposition. While you might think that all muscles on the thumb side are innervated by the median nerve, that's not the case. And remember, it's the median and ulnar nerves that are a pair here in the anterior forearm and palm, not the radial and ulnar nerves as in the paired bones. I always remind my students not to be tempted to link radial and ulnar nerves, since the radial nerve supplies the posterior arm and posterior forearm. So while you'd think that given the ulnar nerve supplies all hypothenar muscles of the little finger, the median nerve might supply all muscles of the thenar group. There are some specifics and exceptions. After passing through the carpal tunnel, the median nerve gives off what's called its recurrent branch, and this branch makes a U-turn just distal to the carpal tunnel and backtracks toward the thenar eminence. And while the abductor pollicis brevis, opponens pollicis, and the superficial head of the flexor pollicis brevis are supplied by this recurrent branch of the median nerve, the deep head of the flexor pollicis brevis is supplied by the deep branch of the ulnar nerve. This is because that deep branch of the ulnar nerve enters the palm medially, dives deep, and then takes a J-shaped course across the palm, supplying numerous deep muscles before it terminates with its supply of the deep head of flexor pollicis brevis. There's one more thumb muscle that isn't part of the thenar group. It's adductor pollicis. It's within the web of tissue between the index finger and the thumb. Adductor pollicis is said to have an oblique head originating off the second and third metacarpals, as well as the capitate and trapezoid. Its transverse head originates off the third metacarpal. The heads converge to insert on the medial aspect of the base of the first metacarpal. That's the metacarpal of the thumb. And both of those are supplied by the deep branch of the ulnar nerve. Now that we've reviewed all the muscles that act on the thumb, let's cover thumb movements, which aren't as intuitive as you might think. Abduction of the thumb takes it as far away from the palm as possible, at more or less a right angle to the palm. Pulling the thumb back to alignment with the palm is adduction. Fanning the thumb out in line with the palm is actually thumb extension. And bringing the thumb across the palm but close to the palm is flexion. Opposition of the thumb is really a combination of abduction and flexion to the point where the thumb touches the little finger, though you can also touch the thumb to the other three fingers. Our all-important prehensile thumb gets no less than 8 muscles, 2 of which have 2 heads, and these enable its many essential movements. Before diving into the final muscles of the palm, we should review that after passing through the carpal tunnel, the tendons of flexor digitorum superficialis and flexor digitorum profundus travel on to the 4 fingers. Remember that the superficialis tendons attach to the base of the middle phalanges, while the profundus tendons attach to the base of the distal phalanges of the fingers. But consider that profundus is a deeper muscle than superficialis. Among my favorite architectural features in the body is seeing the superficialis tendons fork at their insertions to allow the deeper profundus tendons to pass through. Mummy-like wrappings on the anterior aspect of the fingers, known as osseo-fibrous tunnels, act like retinacula for the fingers and hold the flexor tendons to the phalanges. While there are no intrinsic muscles on the dorsum of the hand, the tendons of extensor digitorum are also important to muscles of the palm. This is because of what's called their extensor expansions, also known as extensor hoods. These expanded tendons are continuous with the osseo-fibrous tunnels that wrap around the flexor tendons on the palmar side of the digits to help keep them in place. Since they have common actions related to those tendons, let's discuss the three remaining muscles, or really sets of muscles in the mid-palmar region. These are the lumbricals, the palmar interossei, and the dorsal interossei. Now, the four lumbricals originate on the tendons of flexor digitorum profundus, and they insert on the lateral side of the extensor expansions of the extensor digitorum tendons. Interosseous translates to between bones, reflecting the depth of these muscles in the palm. The palmar interossei are 3 or 4 muscles, that's variable, which originate on the metacarpals and insert on the extensor expansions of the extensor digitorum tendons. The 4 dorsal interossei are even deeper than the palmar interossei and are actually best seen on the dorsum of the hand between adjacent metacarpals. Each dorsal interosseous muscle has 2 heads from adjacent metacarpals that converge and also insert on the extensor expansions. All of these muscles, the lumbricals and palmar and dorsal interossei, originate on the palm and cross the metacarpal phalangeal joints on their anterior side. So would they flex or extend those joints? If you said flex, you're right. But then the lumbricals and interossei all pass posteriorly to share attachment with the extensor digitorum muscles. So for that reason, they also act to extend the interphalangeal joints. It's hard to imagine a palmar muscle that can flex metacarpophalangeal joints while extending the interphalangeal joints, but all 3 of these do because of their dorsal insertions. In addition, the palmar interossei adduct the fingers toward the middle finger, which is considered the central axis of the hand. The dorsal interossei abduct the other fingers away from the middle finger. To remember this, the words pad and dab are used, like you could take a pad and dab up something that's been spilled. The palmar interossei adduct, that's the PAD, and the dorsal interossei abduct, that's the DAB. I should mention that the web of the hand between the thumb and the palm is not just a single muscle. We not only have the abductor pollicis muscle on the palmar side, but the posterior aspect of the web is the first dorsal interosseous muscle. So there are really 2 muscles that make up this web of the hand. Both the palmar and dorsal interossei are supplied by the deep branch of the ulnar nerve. But to understand the innervation of the lumbricals, remember that the median nerve passes through the carpal tunnel. Then it gives off that recurrent branch that makes a U-turn and supplies most muscles of the thenar group. But the rest of the median nerve continues into the palm and has a motor branch that supplies the lateral 2 lumbricals, those of the index and middle fingers, while the medial 2 lumbricals are supplied by the deep branch of the ulnar nerve. The rest of the median nerve supplies the skin of the thumb and 2½ fingers, since the ring finger is half supplied by the median nerve, but its medial side is supplied by the superficial branch of the ulnar nerve. This is because each cutaneous branch, known as a common palmar digital nerve, splits to supply the facing surfaces of 2 fingers. That's a common pattern seen in fingers and in toes. This is more of the redundancy that helps ensure overlapping supply. Finally, and related to this, we still need to return to our clinical issue, the woodworker who sustained a deep cut to the middle of his palm. The tool cut deeply into the center of his hand, leaving his thumb nearly non-functional except in extension and adduction. He also had trouble controlling his index and middle fingers, though they could move. He had feeling in his pinky and medial side of his ring finger, but not his other fingers or thumb. What happened here? Well, the lack of feeling indicates a nerve, but which? If you said the median nerve, you're right. It provides some sensation to all digits except the little finger. In addition, the median nerve's recurrent branch supplies 2.5 of the thenar muscles, abductor pollicis brevis, opponens pollicis, and the superficial head of the flexor pollicis brevis. And he's having issues there. The man does have thumb extension, since it's the radial nerve that controls his snuff box muscles. He can still adduct his thumb because the deep branch of the ulnar nerve supplies the adductor pollicis. He can move his fingers since apparently the cut wasn't deep enough to damage the tendons of flexor digitorum superficialis and profundus. But why has he lost fine motor control, especially of his index and middle finger? That's because the median nerve also supplies the 2 lateral lumbricals, and the lumbricals help us fine-tune finger actions. Now, let's move on to our cadaver lesson and view the bones, muscles, and nerves of the upper limb, so you can get another view, a more realistic view of all the wonders of the shoulder, arm, forearm, and hand.